Senator Murkowski.
Thank you, Mr. Chairman, and thank you to the panel. So many of my constituents back in Alaska live in communities where there is not a pharmacy in town, or if there is a pharmacy, it's a very small pharmacy, and they likely don't stock a lot of specialty drugs. So much of what Alaskans receive by way of pharmaceuticals come to them through the mail. So pretty basic question here then, if it's going to come through the mail, why not work to expand that available market? And for many, they look at our closest neighbor, which is Canada, and say, well, why can't we just get our pharmaceuticals through the mail and through licensed providers in Canada? Obviously, that has been a subject of discussion here in this committee room. But what is the answer to a situation like Alaska or many parts in rural America where you receive your drugs by mail? How do we work to ensure not only the safety and the quality, which of course we want to do and make sure that the FDA is regulating appropriately, but really to allow for a level of access to people in rural America? And I'll throw it out to any of you. Doctor, at the end.
And so I think that we are working and getting a lot of mail order activities in the drug system. So I think in most of the places in Alaska, Federal Express gets your pharmaceuticals.
No Federal Express in a village.
No, I understand that,
Yeah.
but in many places...
They'd like it.
Exactly, but in many places it is in fact available, and they are. The delivery system is working very well in the system, maybe not in the villages in Alaska, but in most parts of the United States. The distribution system is working as long as it's not a very limited distribution system, as Senator Collins and I were talking about earlier. So I think that's it. That's not where the cost increases are occurring, not in the distribution system. It's really in the cost of the PBMs, and it's
Right.
the cost of the basic pharmaceutical companies. So that's where the cost is. So I don't think we're going to be talking a lot about distribution systems here.
Mr. Mendelson?
I agree with the comments about home delivery, that it's a vital aspect, and I don't think that is going to change, and we'll see more and more of that as more benefit managers encourage those programs. With respect to the importation issues, and this dates back to when I was running OMB Health under the Clinton administration, and that was also being proposed around that time. And talking about things that are cyclical, every 3, 4, 5 years, there's an example of a drug that comes in from outside our borders and really hurts somebody. Mm-hmm. And as a result, I know that the Congress had essentially put a certification in front of the FDA commissioner and said, we need the commissioner to certify. And you had Democrats and Republicans in those positions, and to date, no one has been willing to certify to the safety of the importation program. So that does give me some level of pause in terms of, essentially abandoning the protections that we have in this country that are tightly regulated, not only by the federal government, but also by states, and essentially kind of adopting an external regulatory regime.
Let me ask about the PBMs, because you have raised that, and it just seems that we've got kind of a self-reinforcing spiral when it comes to certain drug costs. First, you've got new drugs and they cost more money, and that drives up the cost of insurance. And then in an effort to reduce the monthly insurance premiums, insurers offer this array of plans that expose patients to more out-of-pocket costs. Then PBMs can negotiate some sort of a discount from a manufacturer in exchange for certain concessions, but those savings then aren't passed on to the patient buying the drug. Instead, those savings are already built into the cost of the patient's insurance premium. But somebody who's bought only the insurance that they can afford, they can't afford the steep price of the drug because the insurance has a copay or a high deductible. And the higher the list price of the drug, the more of a discount then that the PBM can negotiate, and the more money then that PBM earns. So it seems that you're incentivizing the pharmaceutical companies to set a list price that is nowhere close to the actual cost of the drug, even when the R&D factored in and the cycle starts over again. So what do? Do we, I understand that Mr. Anderson would either eliminate the rebates to PBMs and PDPs or mandate transparency. I mean, how do we get out of this cycle that it clearly appears that we're in?
So I think what you want to do is pay the PBM a fee for their services. They are performing a very valuable service. And what you don't want to do is pay them, give them a portion of that rebate, because that gives them the incentive to raise the price.
So just a flat fee or?
A flat fee or some kind of incentive payment, but not based upon the price of the drug. So you take away that rebate incentive to do it. I mean, if they negotiate a better price, they can get a bigger fee, but they don't get a rebate.
Got it. Dr. Howard?
Some employers do just that. I forget what the exact numbers are off the top of my head. I think about half of large employers ask for 100% of the rebate to be passed through to them, so they capture the full value of that, and then the PBM can be paid on a per member flat fee basis. You can ask the other 50% of employers who don't do that why they don't do that. I just wanted to draw attention to some innovative approaches on the payment end. There was a study that United Health is trying to replicate where they tried to bundle physician payment services for cancer medicines and for cancer care delivered that physician delivered in the hospital. In a nutshell, they found that drug costs went up by, I think, 136, 139%, but total healthcare costs for treating those cancers fell by 36% because the physician had an incentive to use a regimen at their own discretion that they felt would prevent other complications, prevent hospitalizations. They're trying to duplicate that experiment, but that's one way of putting the medicine at the center of a better outcome that can lower total costs and still force the manufacturers to demonstrate how they're impacting that outcome.
Thank you, Mr. Chairman.